we're a little bit over time, but we'd love to have some questions. If anyone has any, I'll run around. Unfortunately, Louise had to go back to clinic, so she's not able to join, but we still have our 3 other panels. Oh, she's still there? Oh, we might be able to get her. There you go. If she can join. Any questions? Yeah.
Sorry, there's a bit of feedback. There's been mention about the need to discuss that we're doing an HIV test with patients, particularly when we're bundling it with care. And I guess as we are trying to do this as more routine practice and for all sorts of different indications, we've moved away from formal consent for the test, but we're still discussing with patients, but we don't discuss a lot of the other infectious testing that we do for routine bloods. If I see someone's LFTs are deranged, I'll just request routine hepatitis serology without explicitly discussing that, but it still seems like HIV's treated differently. I guess if we're going to do things more routinely and reflexly in the lab, is it time we move away from explicitly discussing that at all with patients?
Yes.
I think it's still reasonably important that we give patients some idea of what they're being tested for, and maybe not in terms of describing every single test that we're requesting for them, but we might be saying, look, for general health benefits, we're going to check your blood count, your kidney test, your liver test, a syphilis test, and an HIV test. And that way, on the odd occasion, when we come back and see the person 2 or 3 days later, or when we ring them on the phone 3 or 4 days later and say, actually, your HIV test is positive, they're not saying, oh, no one told me I was having an HIV test. If it's just been mentioned to them that they've had it, then they know it's there in the background, and then it can be, covered off as you go forward. But I don't think it needs anything more than that at all. And I think if you phrase it in terms of this is for your health benefit, we're doing this battery of tests, then the vast majority of people are going to be very comfortable at having tests.
No question really. So your antenatal testing, is that it's done routinely? Is it discussed? Is it added to the?
It's meant to be discussed. I couldn't tell you how the lead maternity care or the GP discusses the intricacies of each, but I think that the principle should be the same, which is HIV is no different from any of the other tests in the bundle. And similarly, if you're in the emergency department, if somebody's going to take 5 minutes to explain every blood test that you're having, they can explain HIV as well. But I wouldn't single that out. I mean, I think that's the whole point of the movement away from that is if we're not discussing every single thing, it needs to be the same.
So the major impediment to rolling out universal or consent waiver ED testing in Aotearoa is apparently our Code of Rights. And Gary and I have been pursuing this with multiple legal opinions, multiple ethical opinions, and I think we've come a bit stuck. I don't think there's anything else to say. I do think, though, that's just a step towards general population testing. For us, we know there are 20,000 people living with hepatitis C who are not diagnosed, and the only way to find them is general population testing, presumably in primary care. And there's a real push to combine that with a hepatitis B testing that would be informed consent, and the question would be, would you combine it with HIV?
Yeah, I think every opportunity that you've got for testing everyone for HIV is a good idea because, we've moved away from at-risk people because everyone has risk. Well, nearly everyone. Nearly everyone has had sex with someone, and if you've had sex with someone, you've had a risk. So, yeah. So we should forget about who we need to think about testing or not and just test everybody. But obviously, testing everyone can be has cost implications.
Yes.
So it's yeah.
But you do address those or mitigate those risks by combining it with low-cost diagnostics and a registry. And the registry is the only way you can prevent duplicate testing.
highlight that for many clinicians, they would need to do a lot of tests before they get a positive one. So sometimes there's a fear of what to do with the positive result. So reassuring clinicians that we're ruling it out. But as in the final speaker mentioned, as we diagnose the early people or prevent the early people, we are going to have that same proportion of people with late and delayed diagnoses. And the other concern from clinicians can be how quickly can they be linked to care, and what do I do if I come up with a positive result? So clinicians know what the process is in your area for support from an ID or sexual health physician is really important, which I'm sure you have those supports there in New Zealand.
And I think, Simon, you've kind of gone along that road by looking at the new diagnoses that come up, and there's data and analytics that can support that, just to ensure that they do get linked into care if they're not already in someone else's jurisdiction.
Certainly, we in our department have a policy where we'll see people and start them on treatment within 2 weeks of their diagnosis. And over the last 3 to 4 years, we've been able to maintain that. And recently, we've been having notifications from Gary's laboratory in terms of each positive result and making sure that there aren't people that are falling through the gaps. So our nurse specialist, nurse practitioner will track down anyone with a positive result just to make sure that they are being followed and are linked to care.
Hi, I'm a general practitioner. Just in terms, probably more for Gary, and you're talking about changing e-forms, particularly in this sort of resource-constrained environment where there's several tests that we're being asked not to do in primary care. I think you've got pop-ups that come up with your Hep B and Hep C testing requests that kind of immediately prompt a sort of like, oh, should I be asking for this test? And I just wonder, if that's something that is actually preventing people doing routine tests.
So that's interesting, because I think we probably developed those with Ed several years ago, and I wonder if it is a time to sort of reconsider that. They've certainly been very effective in increasing the proportion of people who have been appropriately tested, and what we look at there is people who, so a lot of people before they were brought in were people with hepatitis C who were known already to have hepatitis C. And so we demonstrated that we increased the appropriateness of testing from 50% up to 95% using those boxes through the e-orders. But it probably is, as you start to expand your need to find people, a time to look at the appropriateness of those again. But certainly the idea of any of the prompt boxes is to make sure that we're doing the right thing rather than restricting it in areas where we should be finding people.
In Victoria, just in relation to Louise's comment about the perhaps the disconcerting positive test for a GP that has never delivered a positive test to someone. We actually have managed to get a little statement on the bottom of the confirmatory test from our central lab that says if you require assistance in delivering the diagnosis or you need help, please contact the GP Connect phone line on this number, where one of our nurses is on the end to help that GP deliver the diagnosis, but also connect that person to care if they don't feel comfortable. So that's one thing that can be done. I was just going to also say that I favour telling people that they're having an HIV test because in Victoria at the Alfred we see all of the blood donors who test positive on blood donations. They never know they're having an HIV test. This is a total shock to them, and the delivery of care to someone that was not anticipating that positive test is just so much harder than for someone who knows they're being tested and it's in their mindset.
and I can only talk from my experience from working in South Auckland, and I've been in New Zealand for the last 10 years. The awareness about HIV in this country is very low compared to places like the UK or Colombia, where I was born, which results in people very reluctant to engage in testing because they're not aware of the modes of transmission, especially in the heterosexual community and in the Pacific and Maori community, which I think is a comment mainly to say that we need more public health campaigns, very much like the hepatitis C, to try to raise the awareness about STIs altogether, because we're seeing an increased number of chlamydia. And I work in the drugs and alcohol service, and many of my clinicians don't even know what syphilis is. We have a very low health literacy. But my question was, how do you think that the Fiji outbreak could impact New Zealand, and how we're going to respond, especially as we have such a constant transient population, and Fijians and in the Pacifica, they're very reluctant to talk about sex practices and testing. So, any ideas about that?
I don't know that I have any specific comments about that. I guess it's just a matter of being able to offer as much testing to as many people that we see that we can, and I guess being aware of information that's coming through, so that general practitioners and so forth are aware that there are issues in the Pacific, and that the Pacific patients that they may be seeing, not that we have moved away from thinking about risk factors, but obviously if it's clear that there are potential populations that are more at risk than everybody else, then GPs being aware of that sort of information so that they can continue to offer more testing, and I guess be supported and from various areas to be able to do that. But I don't have any specific comments about that.
I wonder if that's something for Gane and Rose to comment on. Is there a way that you can target testing towards incoming Fiji immigrants?
It's not immigrants, it's people's work and travel.
Okay, yeah.
And like people, for example, one of the hairdressers, they people come and go, and they're very reluctant to test. You cannot, even in my setting, that they say don't test me. I was saying that to Rose, because they're not aware of the modes of transmission, and even my clinicians are telling me, it's all well and good, but I don't really know anything about this, because it's never been in the forefront of their minds. Because we never, and when I ask my colleagues to test, it's like, there are very low numbers, we don't need to test. That is the percentage that we have in our health services. And we need to change that, because we don't have hepatitis C. Yes, we don't have the numbers yet, but how many more do we need?
Russ, but a virologist here at LabPlus. So just going back to universal screening. In the UK, if your prevalence is less than or more than 2 in 1,000, it becomes cost effective. So I'll be more, and I don't think we at that prevalence in New Zealand. So I would be more in favour of targeted screening. So coming back to GPs, for instance, in terms of e-ordering, if we have a tick there saying your patient would be reflexed for HIV testing unless you untick this box, I think it would be very helpful, because then we can go according to lymphocyte count or platelets, for instance, or if they've ordered EBV test, we can reflex it onto HIV testing. So I think we need to look at areas where we can find more infected patients rather than just a blanket universal screening.
I guess my comment would be yes, I agree with you from a cost effectiveness perspective, and then it would probably be a graduated approach, wouldn't it, as you start to lose your case finding ability in those groups, you have to cast the net wider.
So Raz, when you mean general population testing, the way hepatitis C has been rolled out in Europe and Ireland and other places, it's adults. And places like Italy, they have a stratified age cohort. They're testing the younger first and then the older, because the rates are well above that. And in this country, the rate is probably between 0.5% and 1%. For hepatitis B in our adult population, it's over 2.5%. So it's, and if you bundle, if you're going to test somebody in primary care for hepatitis C, which we have to do at some stage, and hepatitis B, adding on HIV, does that significantly alter the cost effectiveness if it's part of a panel?
Yeah, it still adds the cost. So if you add $8, say, per test, if you're going to do 1 million, like they've done in the hospital you've showed, or 2.5 million, the hospital in London, which you've showed. So that's a huge cost. And if we can afford it, then it's fine. But, you know, if we've got to choose where we're going to spend the money, then the argument could be, if we roll this out and we don't pick up that many new cases, then we're going to damage our cause, to be honest.
Other argument is it's a one-off test. So you do a national screening program and it's done.
Just in terms of timing, we're running really behind now. So we'll just have one last comment or question from Jeannie, and then we'll move on to lunch because we're all waiting for that.
Yeah, I guess it was just a comment thinking about the Fiji situation. You know, I think we should leverage off what we've already got. For example, Gary helped to set up the bundled STI testing that can be accessed through primary care. And so, you know, it's about putting out the MEDINS messaging, raising awareness and encouraging primary care to use that bundled tick-the-box approach. I mean, that tick-the-box test for HIV and syphilis, but, you know, you do wonder, in terms of your thoughts, Ed, whether another bundled box couldn't bundle up Hep C, Hep B, HIV and syphilis. We can't forget syphilis.
Okay, and on that, we'll finish.